Let me introduce our other panelists before we launch the conversation. First is Diane Jacovella, who is the Vice President of Multilateral and Global Programs at CETA, who has responsibility for CETA's institutional relationships and programs with large multilateral institutions, also has thematic responsibilities for CETA's programming in food and nutrition and maternal child health, et cetera. So, Deanne, welcome. We have Lynette Neufeld, who is the Director of Technical Services at the Micronutrient Initiative, and Howdy Buis with Harvest Plus, which is a very interesting program that we'll learn a bit more about in a few minutes. Welcome all, and thank you for agreeing to participate. Bob, thank you for your remarks. You've laid out the moral case for doing this. You've laid out the research base upon which we're working on it. Heck, even the economists agree.
It's hard to imagine, isn't it?
Well, I mean, it seems to be one of those issues which has a very unique, maybe entirely unique, confluence of stakeholders and thinking processes behind it. Why is this still an issue?
Important question. Nutrition has been seen as a rather difficult problem to tackle, and I think not so long ago, even 4 years ago when we reviewed the world situation, one could say that there was a rather fragmented approach to addressing nutrition, especially maternal and child nutrition. And I think what's happened in the last 4 years, for a variety of reasons, is much more coalescence around a commitment to address child nutrition, let's say, or maternal and child nutrition, and organizational coordination and agency commitment that is, I think, is different now. I think in the past that was not there. And I would say one other thing. There is a great deal of effort and investment going on in regard to agriculture and producing additional crops and calories for the world. And that's obviously important. It's important to meet the need now and meet the need of a growing population. But I think until recently, there was not enough discussion on the nutrition aspects related to agriculture to be sure that the enhancements of crop productivity really help meet nutritional needs, that income that was perhaps generated by these crops could be appropriately used and in the hands of the families that needed that. And so, I think the world is changing, and I think now there's, to me, a much greater commitment to see the problem solved.
I mean, Bob, was this just an issue of the nutrition people not talking to the agriculture? Was this just an issue of knowledge silos or programmatic silos?
Right. So, I think what we've all seen is that there has been a great deal of emphasis on particular diseases, HIV, AIDS, even historically diarrhea as a disease.
These so-called vertical programs.
These vertical programs, exactly. And with those, and some of those vertical programs made a difference, there's no question. But, nutrition sort of got lost in the process because it's, other than in an emergency setting, it's not seen so much as a disease, it's not seen as with certain urgency to deal with. And I think the, recognition that this was really such an underlying problem for many of the deaths, many of the, causes of severe disease, was just not there. It was not appreciated, the magnitude of it or the consequences. And as I said, some of the micronutrients were hardly appreciated at all as part of that problem.
Bob, it seems to me that the whole question of what and how much people eat is a tough question, even in this part of the world.
Sure.
Right. And it implicates a lot more than just knowing. Presumably people have to think about changing a lot of their practices. How much of the challenge here is not just getting the knowledge base right, not just getting the donors and institutions aligned, but actually trying to figure out what it takes from a public health perspective to get people to change what they have typically done?
Well, certainly changing behaviors, especially deeply ingrained behaviors, cultural behaviors, such as how to feed children, is not simple. But I think if you look at the economic development of countries, as families have more income, they do improve their diet. So there is a major element of poverty. They don't have the option to have a diverse diet. They don't have the option to, have animal source protein with the micronutrients involved in their diet because they're poor. And so, it is a behavioral issue, but it's also a poverty issue. Right. And I think solving the poverty issue and also providing the right nutrients, in that environment, I think that's part of the solution.
Diane, Canada actually has been a leader on this for some time, not kind of jumping on the bandwagon recently. I mean, the MI is an institution that is many, many years old. How are you seeing CETA's priorities today in the whole area of nutrition?
Maybe just even before talking about priorities, I just want to emphasize what you said. I think we've seen from a long time that we needed to look at direct intervention on what's happening now, but also looking in the long term where the difference will be. And this morning we were talking with Haldi and we're saying, well, the results we're having today are actually funding you gave us 10 years ago. So right. I think it shows the importance of having also a long-term approach to some of these
and to sustaining that investment over time.
And sustaining this investment. I'm just thinking back in 2010 when the scaling up nutrition movement actually started.
This is so-called, we call SUN. Yeah, right.
SUN. We were there from the beginning in terms of working with the World Bank and some other countries to, MI was part of this as well, developing the framework of what it is. And we've been there also in terms of launching the movement. And, you were saying there wasn't any attention, and you're right. Like, people were not paying attention to this because some people were seeing it as a health issue, so the health people will worry about it, or no, it's an agriculture issue. The agriculture people can worry about it. I think what we realize is that we all need to look at it if we want to make a difference. So I think for me the priorities is, maybe I'll outline 4 quickly. One is I think we need to continue to invest in direct intervention. We know, like Bob just said, we know what works. We know a small investment can have significant impact. We need to continue doing it.
And a direct intervention for you is fortifying something.
Vitamin A,
right.
The zinc that we're talking about with oral rehydration salt. So those kinds of things that we're doing, we need to continue doing them. But we also need to look at what we call nutrition sensitive interventions. And this is the money we give to agriculture. Can we make sure that it's not just, we're not just raising the yield, we're also raising, I would say 3 things. The yield, the income of people so they can spend money elsewhere, and the third one, the nutritional impact.
So it's kind of putting a nutrition lens on the agricultural investments as well.
But we need to be careful that we just don't take it for granted that if we say it's going to we'll do it, it's going to happen. Right. So we need also to build the evidence that if you do it a certain way, it will actually have a nutritional impact. Okay. And there's not a lot of organization. There's a lot of organization now that try to include nutrition consideration, but that measure it. And I think that's one of the things that Harvest Plus is doing, is that making sure that they're going to measure to see at the end, are we actually having a nutritional impact?
Right.
The third one I would say is we need to build different partnership, different relationship. And we need to bring all the stakeholders, and that includes the private sector. Mm-hmm. And sometimes there may be some sensitivities. There was always, in terms of the issue of breast milk and those kinds of things. And but there's ways of bringing the private sector, and we need to work with them for them to bring the know-how, the expertise they have, all the production, the value chain aspect. So if Harvest Plus finds great seeds, but there's no one to take it on, then it won't work. So we need to look at our partnership, and I think we need to use all the platforms that we have to make sure that the nutrition message is there. And the fourth thing quickly is, I think, accountability. For Canada, accountability is a premium, and I think we are recognized internationally for paying what we pledge. And we've shown that at the G8, that, don't come with big announcement, make sure the money is there and delivered. So pay what you pledge, and also accountability on results. And the work, you were on the commission that was co-chaired by Prime Minister when, we identified specific goal for maternal, newborn, and child health, and indicators, so we all work towards the same outcomes, and we measure what we do.
And is CETA going to be working across all these priorities that you've outlined, these 4 priorities?
Absolutely.
Yeah. Lynette, we see the MI as kind of an elemental institution in the nutrition landscape globally. Obviously, great affection for it as a Canadian institution. Tell us a bit about how MI fits into some of the issues that have been raised so far. Where does it fit into the portfolio of institutions that are doing work today in this area?
Okay. MI, I think we could call the leader in promoting and implementing, with the support of CETA, for the last 20 years, if I'm not mistaken. The 2 major interventions, well, the one major intervention that was mentioned by Bob in terms of vitamin A supplementation. Right from ensuring that the policies are in place and supporting governments in the development of those policies to ensure the programs are implemented, through the procurement and distribution issues that are vital. Can't have a program if you have no product. But also ensuring that the structures and the delivery systems are there, and those contact points with the population are happening with the partner organizations that are on the ground and implementing programs in the country. So if you take a step back from that one, that's what we call our strategic objective related to child survival. It's a key intervention to ensure that children survive. Now, more recently, we've also added with the same lens, working through from policy all the way through delivery, and again, getting the delivery and the utilization of that in the population for the zinc for treatment of ORS. So those 2 are really our portfolio of programs related to child survival. But if you think of an analogy of development, it's important that it's like alleviating poverty, right? You want to make sure that the immediate need is dealt with. But that's not the only thing. The only reason those programs are needed is because children are deficient and women are deficient. If they weren't deficient, we would not need those programs. Children would survive.
So they're deficient in vitamin A and zinc
vitamin
before you even get to them.
Absolutely. And their mothers are deficient. Their mothers were deficient as children, and therefore they didn't grow as they should, so the babies are small, and they don't have the reserves that they needed. And those women, their mothers were deficient, and so it becomes ultimately an intergenerational problem.
So upstream of the deficiency that you're dealing with, you're trying to understand what are the chains of issues before then.
We know that. We know that. The problem with that one is it's not an easy sell. You know, what are you trying to sell there? When you're trying to sell child survival, we're going to save millions of lives. That's an easy sell for CETA to take to the people who have the budget in hand. Some of the other areas where we're working on, which is child growth, child development, the fact that we do these interventions and those children are going to be taller, who cares?
Who needs taller kids?
Who needs taller kids? You're going to have to change the buses because buses are small. Why do we care that children are taller? You know, I care that children are taller because I know that a child who hasn't grown to their genetic potential also doesn't have the same potential to survive. To survive. They also die easier. It's not that immediate need, but it is still there. Their immune system is still compromised. Their development is compromised. When they get to school, they will not be able to have the same achievement in that school as a child who has reached their growth potential, because in parallel with impeding their growth, their mental development is impeded. And when that child who has had that impediment from young age is also physically has a physical impediment to reach their full work capacity.
But Lynette, what do the actual interventions look like upstream? So, I mean, I think it's very clear to us now what supplementation looks like in the face of an actual deficiency. What do we know about what works upstream of that?
We know a lot. We have a lot of evidence. We know that breastfeeding up to 6 months of age is vital. Well, exclusive up to 6 months of age, hopefully up to 2 years of age, complemented by other things. We know that if the quality of the food that children receive between 6 and 24 months of age is adequate, as in it has enough not only energy, essential fats, and protein, but also the vitamins and minerals, that child will grow to their potential. And we know that. And we know many things about how to get those nutrients to the children. What do we give our kids? Do you just give them a little bit of that soup that you're having? to your 6-year-old? How many people to their 6-month-old, give the same thing that you're eating? Do you take a few spoonfuls out of your plate and give it to that child? No, you don't. You give them baby food. Why do you give them baby food? Because they need a different texture, they need a different consistency, and most importantly, they need a different nutrient density. And we know how to get that nutrient density up. Industry has got it perfected. The problem is that in many countries around the world, in many populations, those foods aren't accessible or they're not affordable. We also know ways that we can increase the quality of that food by other interventions that are easy to deliver. We have micronutrient powders that a woman can take that portion of food, she can add it in. It is 1 gram. It does no taste, it has no color, it has no flavor, and she can improve the nutritional quality of that food she's going to give her child by a very, very simple technology. Right? And we know it works. We have evidence from all over the world that it works. And we also have evidence that women accept it and use it when they're provided with it.
Right.
We also know that if you germinate foods and you ferment foods and you change your processing methodologies, the nutrient quality increases.
Right.
It's not a lack of evidence.
Right.
It's a lack of delivery, and it's a lack of these are not easy interventions. These are not get the tablet out there. It's not the model of the magic bullet.
Right.
It's complicated. It's very complicated. It requires a lot of behavior change, both on the part of all the way from industry, all the way through healthcare providers, all the way, obviously, to the home and how foods are distributed within the home and how foods are prepared and provided to children.
Right.
In most rural agricultural countries, women have many responsibilities. They're working in the field, they're caring for children, they're preparing food for the husband. All of those things have to happen at the same time they're giving food to the children. Who has time to make that special pap and all those things that I did as a mother and probably all of the mothers in the room did?
Right.
But we have the luxury of doing that. So we have to find viable, feasible, both economically and practically feasible solutions. Right. And then we have to get them to scale. And we have to get the commitment, just like we have that long-term commitment for the poverty alleviation analogy side of nutrition. We need commitment and long-term commitment for the, let's call it the social protection, for the economic development side of nutrition, using that same analogy. This is the long-term commitment. This is building the schools and investing for new jobs. That's that side of development. Right. That's what we need to do. And that's where, globally, it has not been as easy to get the long-term commitment. And I understand why. Right. You can't take that and sell it to the politician as, I'm going to save 100,000 lives. It's not an easy sell. But we have to find a way to do that. And NMI is committed to doing that. Right. We have some programs. And we also work a lot on the research that's needed, but not those randomized control trials. We know what to do. What we need to know is how to do it.
Well, Andrew Howdy here, in some senses, you're trying to eliminate the need for us to do anything further on this, it seems to me.
It's going to put us out of business.
You want to put this whole group out of business.
Yep. That's good. I'm ready.
Power to you, Howdy. This is often called a hidden disease, and you're trying to find a hidden solution. Tell us a bit about what Harvest Plus is trying to do vis-a-vis the issues, especially this last issue that Lynette has talked about.
What Harvest Plus is trying to do is get the plant breeders to not only breed for higher yields, disease resistance, pest resistance, but at the same time to put more minerals and vitamins in the staple food crops that the poor eat in large quantities. Why do we want to approach things that way? Well, I'm an economist by training. And what's always appealed to me about agricultural research is the multiplier effects. So you can spend money, do research in a central location, and you develop a new seed, a new technology, then you can make that seed available to country after country. And once that seed is in the food system, it's available to consumers year after year after year. So you spend the money up front and you don't have the recurrent costs.
Is this creating superfoods?
No, I wouldn't say it's creating superfoods. I'd also take issue with you that I'm trying to put others
everyone out of business is fine.
It's one way that agriculture can be used to improve iron intakes, zinc intakes, vitamin A intakes in a very cost-effective way. So we're shifting the distribution, the intake distribution. We're doing something where we invest $1, we get high return, and we're helping to solve the problem. But we're not solving the whole problem. The ultimate solution is for people's incomes to go up, for people to be able to afford the diverse diets that we're able to afford. But it takes decades to increase incomes to the level where people can afford the diets that are really required. And biofortification is just something that can be done along the way to help reduce mineral and vitamin deficiencies.
So give us an example, Howdy, of one of the crops that you would try to biofortify. What does it look like? What does it feel like?
Okay, so orange maize. Africans eat white maize. Vitamin A deficiency is a huge problem in Africa. White maize has no vitamin A. We're putting in 15 micrograms per gram into the maize. It turns it to an orange color. And at the levels that Africans consume white maize, if they'll just switch over to the orange maize, that will provide 50% of the estimated average requirement. So it isn't the whole requirement, but they're already getting some vitamin A from the foods they're already eating. And we're adding another 50% on top of that.
Now, how are you selecting which crops you're going to focus on?
Well, in the first instance, you select the most widely eaten crops. So rice, wheat, maize, cassava, those are the 4 most widely eaten. You also look for where the science is easy. And so we found with beans and with pearl millet, we're able to increase the iron content relatively easy from a scientific perspective. And there are also many millions of consumers who eat beans and pearl millet. And then, of course, you may have heard about orange sweet potato. Africans eat white sweet potato. The orange sweet potato was already available here in Latin America, in North America. All we had to do was bring that to Africa, adapt it to the growing conditions in Africa. It was already very high. Sweet potato, orange sweet potato, is one of the foods with the most dense levels of provitamin A in any food.
And what's been your actual experience at trying to get some of these crops in wide cultivation?
Before I address that, I'll back up a little bit and I'll say one of the barriers to this approach was 10 years ago. Right. We had to go to the donors and we had to say, this is really cost effective, this is really going to be great, we're going to have a large impact. But you're going to have to give us a lot of money for 10 years before we have any impact. And that was a difficult sell. And CETA was one of the institutions, one of the donors. CETA is our second largest donor that believed in the strategy and invested in the strategy. Now, we had the orange sweet potato available 4 years ago, but now in the last 10 months, provitamin A cassava was released in Nigeria last December. Just to show you how long this takes, we had those varieties 2 years ago, and we knew they were high yielding and they were high in nutrients. But you can't release a variety unless the Varietal Release Committee tests it for 2 years and confirms that it meets agronomic standards. So now we have that permission, that release. Right. And farmers are now growing high provitamin A cassava in Nigeria. High iron beans were released in Rwanda in June. High iron pearl millet was sold for the first time in India in June. And in the next 2 weeks, the Zambian authorities will release the high provitamin A maize, and they'll be grown for the first time in November in Zambia. So that's kind of where we are. Now, we had the orange sweet potato. Right. We got funding to do pilot dissemination of the orange sweet potato in Uganda and Mozambique. 24,000 target households. We also studied it very carefully. We had control villages, intervention villages. 2/3 of the households adopted the orange sweet potato. Those households converted about half of their white sweet potato to orange sweet potato. Vitamin A intakes increased anywhere from 60% to 100% among the preschool children and the adult women. And we took blood samples in Uganda, and we found that the serum retinol improved because of those improved vitamin A intakes. So we found that when households, especially the mothers, were given the information, if you will grow this orange sweet potato, you'll protect your children from vitamin A deficiency if you switch from the white to the orange and consume the orange. When they had that information, they switched and all these good things happened. Now the issue is how to get that information. I'm an economist.
Right.
How do you get that information at low cost?
Yeah,
and
right.
that's what we're working out. We can go door to door and give them that information. That's very expensive. You can't scale up if you do it that way. You can put it on radio, but you don't have face-to-face contact. And radio messages are cheap, but they don't change behavior. So we're working, for example, through NGO networks. They have their farmer networks, they have their regular meetings, they have the face-to-face contact, they have the trust. So we're getting the NGOs to take on the biofortified crops in their programs and to talk and to give the households this information. So far it's worked with orange sweet potato, and we're just starting with the other varieties.
Right. We're going to be open for questions. So do we have roving mics? We've got a couple at the back. So just wave your hand or, I don't know, make a funny sound and someone will come running to you. Before we take the first one, Bob, so you've heard everyone here. It seems that there's been some change in the last several years, a critical mass of knowledge and focus and institutional commitment. Does it feel different than it did 10 years ago?
It certainly does. I think the scaling up nutrition
Yeah.
movement was mentioned. I think that is a major development. More than 100 organizations with strong leadership from Canada, actually, and I think that's entirely new. We wouldn't have seen that before. You know, there are other related initiatives and movements that I think are very related to sun, but also have some energy. The 1,000 Days movement, which really does focus on that pregnancy and first 2 years, which is part of sun, as I say, but it's also had sort of a separate launch and attention. So, I think there really is more coordination and more concerted action, real commitment than I see now.